This is a video of a conversation between myself and Shelley Barlow where I explore her approaches to pain. And let me tell you, they're incredibly experienced, well-rounded, bedded in physiotherapy, psychotherapy and much, much more. She demonstrates such a compassionate viewpoint, and for any clinician looking at starting to work in this field, it wouldn't hurt at all to listen, to see and pick up on how she describes her approach to patients in persistent pain. For people experiencing persistent pain, there's some lovely nuance in what she says, that if you can pick up the tone and the approach that she suggests as a clinician, but you take the role yourself and compassionately exploring some of the issues, feelings, movements and pains that you experience, you may find you can help yourself more than you actually realise. It's a fascinating conversation and I really enjoyed it, and I hope to speak with Shelley much more, and I hope you enjoy this conversation that we shared.
Better.
Sorted, we're on. Right, thanks for joining me, Shelley. Anyway, so we're two clinicians, half a world apart, 12 hours apart. You looking radiant after a lovely day in New South Wales, Australia. Me, half dead in a rainy northeast of England. Either side of the matrix. But the point of this conversation is to really find out about looking at pain that in the way that appears, especially persistent pain, appears to be more effective than the way that certainly I used to look at it. I was really interested in speaking to you because I think I have the impression, and I'm quite certain of that you've been on the other side of the matrix looking at it, if there's a right way, that way, for a lot longer. So just tell me a bit about you, Shelley, your history as a clinician.
So I graduated a long time ago from Auckland Uni, from Auckland University of Technology, so back in the 80s. I did a Bachelor of Science first, because biology was my most favorite subject. And I was sort of at the end of first year of that, realizing there wasn't any people I wasn't going to be doing anything with people. I was either going to become a lab tech. I was actually wanting to be an evolutionary biologist, but there was no jobs around at that point. There's heaps now, but not so many there. So I thought I better do something with people, and physio kind of came on the radar, and I thought, oh, that'll do. That's like biology in action. And so I'm pretty much trained as a musculoskeletal physiotherapist. And then by about my fourth year out, I kind of went, oh, there's something not quite happening here for me. I had a patient who was somebody with persistent pain. So that would have been about 88, 89. And no matter what I did, didn't matter what I did, it didn't make any difference. So it made me take a whole new look at this idea around chronic pain and persistent pain. So I did what usually physios do, lots and lots and lots of weekend courses. And I did acupuncture and all the McKenzie stuff again, and all the Mulligan stuff again, all the manual therapy stuff again, all the remedial massagey stuff again. And it still didn't make any difference. So by about 94, I was looking at every alternative I could possibly find and landed on Louis Gifford's stuff. And so just followed Louis for about 10 years, just listening and reading his stuff and following what he was doing. And then I got a job in a pain clinic and did more of the guys in London, where a lot of the original pain thinking came from, did their training, and then started my Gestalt therapy training in 2003, and then basically have just tried to combine mind and body for pain ever since, to try and integrate I started my PhD in 2013. I'd done a 2-year research project before that, looking at the emotional world of physiotherapists working for people with chronic pain. And so I spent 8 years doing a PhD and doing a master's of Gestalt therapy. And then now I've still been thinking about persistent pain, and I've just finished a year of Pain Revolution's local pain facilitator. And I've also been looking at the role of burnout within physiotherapy. But my real interest at the moment, what I've been delving into, is the intersubjectivity. So intersubjectivity between clinician and person with chronic pain, lived experience of chronic pain. So the coming together of the two.
Yeah, and we've chatted before a little bit about the concept of right brain psychotherapy. Is that the right term?
Yeah.
And it's a massive subject. I've just some reading of where you've pointed me to. In essence, if you were suggesting that to somebody who'd never come across it as a clinician, and for any patients who are interested, because everybody uses this without realizing it, how do you present that idea to people?
It sort of comes out of the neuroscience purist literature. So Ian McGilchrist's work on right and left brain, it comes out of, Stephen Porges' work on the vagus nerve. It comes out of the interpersonal psychotherapists, but it has its roots way back in neurology from the First World War. And so essentially it comes out of Freud and Husserl, who was the phenomenologist, and Fritz Perls, who was one of the founding thinkers in Gestalt. And I think they intuitively knew that talking about stuff for people who were showing signs of shell shock and PTSD as we know it now, you couldn't make any change for them by talking about stuff. You had to get into a non-verbal, you had to meet the person in what we call a right to right brain synchrony, which, if you look at the neuroscience behind interpersonal neurobiology, it's really mirror neurons, but it's also all those midbrain structures that start to resonate together in synchronicity between when one person's sitting in the presence of another. And the right brain is able to pull together the body-based feelings and also a quick scan of the environment to see threat and danger, but also to see engagement and also to see where safety is. So working on those deep implicit memory systems. And then what happens is the right brain is actually able to make sense of something without words. So it's like a deep interoceptive knowing that everything's okay. And conversely, if it's not synchronized, then everything's not okay, which makes the therapeutic relationship really important in actual regulation of these background nervous parts of the nervous system. Does that make any sense?
It absolutely does, because for anybody who's watching this, whether it's a patient or a clinician, they felt interactions go wrong and they can't put the finger on it. And then they've seen interactions go right and they can't put the finger on it. I mean, we have ideas. It was him, it was her, it was me. The room was too hot, too cold. I didn't ask her name. I didn't introduce myself. I did. Our mums know each other. She knew me from a kid. I went to school with a son. We try and work out why it went so well, or vice versa, don't we? And that mechanism, when you describe it historically, it's theory, isn't it? So is there a way that this is measured now?
Well, they do use quite sophisticated electromyographic information now, and it's actually, some people use it in a way that they get real-time MRI feedback, and they've actually developed, you know, sort of neural retraining equipment that you put on your head, and it, you know, puts magnetic, you know, to change these patterns. But that human to human right brain synchrony comes out of the work of Alan Shore, SCHORE. And it's me feeling you, feeling me, feeling you. So it's the subcortical structures, the ones that have no words, the ones that have no, you know, the left brain's all about putting things into a logical linear structure. The right brain's more about artistry and synthesis and integration. So it's the knowing without knowing how you know. And in some ways it gets into that deep way of knowing that it's right. And you can manipulate, I think, the therapeutic alliance, and manipulate's probably not quite the right word, in the way that psychotherapists do, to actually make contact with the part of the nervous system that knows that I see you, validate you, hear what you have to say, and think of you as a whole and human being, which is very different to how a lot of people feel their response is within health services or within other biomedically based, pathoanatomical based services, where they often feel dismissed and unheard. And
so do you feel that the premise with which we start the interaction a lot of the times is set up to fail in healthcare?
I think the intent of the healthcare practitioners is to care and help people. I think that's what the original intention is. I think what happens is the clinicians meet the other person as an object.
Yeah.
So it's very much, I've got the knowledge and I will tell you what needs to happen, rather than meeting the person from the place where they're at in that moment to find out what's truly going on for them and what they need in that place. Now, often the person doesn't know what they need in that place, so some deeper exploration has to go on, but the presence, attunement, and tracking of the clinician needs to follow the patient, not the patient follow the practitioner. And I think what I found out in my thesis was that health professionals find working with people with chronic pain difficult because they would rather avoid jumping in boots and all and finding out where the patient's really at and what they really need and what they want, and assuming what it is that they want and giving them that, which is I, as an expert, treating you as an object, and then me as an object, seeing you as an object, rather than my subjectivity of who I am as a human being, my selfhood, meeting your selfhood to find something, another way of doing things.
Some people would describe that, what you've just described, as quite a spiritual connection.
A lot of the philosophers who talk about relationships, like Martin Buber or even Jung, or even in psychotherapy world, some of the relational psychotherapists will talk of the meeting of the other as a very a peak moment. It comes also out of attachment theory, so that ability of the caregiver to soothe the infant and the infant to regulate the mother or the caregiver. These are ancient rhythmical, reciprocal, mutually supportive and adaptive structures that have been set up in the human nervous system, a long time. So I think because it's intangible a lot of the time, it does have a spiritual sense to it.
And
without
when you describe about the therapist not wanting to jump in, they have their body of knowledge, sort of stuff. Let's take physio, for example, bones and muscles and joints and nerves and mechanisms, and maybe some neurophysiological ones as part of that. But a lot of what I've come to understand is that there's quite frequently a traumatic background to the person before the pain. And that was never shown to me, suggested to me, or even considered, 25 years ago. And really, maybe I'm not reading the right stuff, but until about 4 or 5 years ago, I was stumbling across this. So if they don't know that there's something there and they're approaching this with a totally different set of goggles on, for it to be suggested to them that they're in a place of the unknown, which for people who like the known is threatening, and so it's dismissed. But what I've found is that if you sit in that space, you don't have to be an expert in trauma recovery. You have to be prepared to go and sit in the unknown.
And that's what I mean about the clinician's avoidance. And it's not malicious or it's not deliberate. It's a unconscious, I think, primarily unconscious, that because of the intensity or because of the lack of training, or because of how we're shaped by our training to see the world a particular way, we just don't have the blueprint. We're not organized to see the other person as a human being who may or may not have come from a trauma background or had a trauma response or having a stress response or having some kind of upregulation of their system. And so we just don't see it. So we don't have the emotional availability to meet that. And because it becomes so uncomfortable, we just fall back on what we know, and which is, well, here, do 3 lots of 10 of this, or, go for a walk or whatever, rather than sitting in the discomfort of the uncertainty, and the ambiguity and the unfamiliar environment, and just being present with what is there in the room at the time, which is often a very human response to a situation that's untenable most of the time. To sit with chronic pain day in and day out is very difficult. And if you have a clinician who dismisses you or even has a whiff of contempt, and you've come from a trauma background where you haven't been seen, heard, and validated either, or even hurt in some way, it's just going to bring up the same pattern of experience that you've had.
Mm-hmm. So when you you describe a spectrum of training there, and a lot of it you might consider was useless, but actually everything has its place, doesn't it, with an interaction, even though you might not see it. I remember Steve Jobs saying that he couldn't understand why he did a calligraphy course as a major or something, and it wasn't until years later he looked at the fonts he designed with Apple, and it pretty much mirrored a lot of that work. So now that you have this spectrum and this journey that you've taken as a clinician, and kind of, I feel like I'm on that as well at the moment, how do you set the scene now with your interactions? Because you work, obviously, you're studying in academia, but you work clinically as well, don't you? How do you set the scene?
Well, I work in outpatients or in the community. So I'm still in a community health setting with just, I tend to see people with more complex presentations of pain. And I work alongside musculoskeletal physios who see people immediately post-op. Essentially, in the clinical encounter, I start from a place of the first part of that is to meet the patient where they're at that moment, rather than come into the encounter with a preconceived idea of what I'm going to do. So it's essentially swapping around the encounter to bring that person into a radical place of being central. And I know patient-centered care is all over the place, and I know all of that is all over the place. But this is a radical divergence from me coming into the encounter. It's almost like coming in with a beginner's mind, but my intention is to meet the need of the other. So in all the literature, they look at pain as a need state as much as a sensory emotional experience. So in the same way as thirst and hunger and love and belonging and all of that. So it's a need state, and the action is to seek care. So in coming to see me, the contract is around seeking care, seeking understanding, seeking knowledge. So I need to find out exactly what it is they want and they need in that place. And then that's the starting point.
And you mentioned before that when you presented these ideas to me and to your colleagues, that people might, and we talked about a particular technique called all pain to go that we've both played with a little bit. That how is your approach, maybe including that or some other more nuanced techniques? How's that viewed by other clinicians? Because did you say they just they might think you as just send the complex ones to Shelley, as if they don't understand what you do quite?
Oh, I think I must come across as being completely weird, because my starting point after sort of finding out and establishing contact and where somebody is I'd like to try and get as much of the white noise out of the situation as possible. And how I frame up the white noise is the white noise of the nervous system. So where the nervous system of this person, or where their system, or where they're dysregulated, where they're not, and this is probably sounding very fluffy, I suppose, for want of a better word, where their system is not calm, where their system has been, in the words of Lorimer and all his team, where it's been perturbed. So what's keeping the system desynchronized, or what's keeping the white noise in the system? Why the system is not settling? And the contributors to that are not apparent initially. Old pain to go is one avenue of regulation. So it's a one way, and some people really like it, and other people it doesn't have a lot. It doesn't. It's not enough for them to regulate. But the suggestion that their system can regulate itself by paying attention to calming, to release of old ways of neural patterning, can actually be an avenue into other forms of regulation, other forms of turning this white noise around. So I kind of go searching for where I feel that I'm a little bit dysregulated around this person, and if I can feel it in my body, then I'm assuming that's what they're feeling in their body, which comes out of the phenomenological literature or the phenomenological world. So phenomenology is a form of philosophy, but it's also a methodology for research, but it's also a methodology for psychotherapy. So it's using the felt sense of the situation to work out what the other person's doing. And if you think of that, then you're looking at right to right brain synchrony. So if I'm feeling in my body what is going on when I'm in the same room as you, and I step out of the room and I'm not feeling that, then I'm probably picking up what your system is doing. And I can use that as a signpost to gauge what level of dysregulation your system is, and then we can start to work.
Yeah. And so do you start with yourself?
Always.
Yeah. And again, it's another thing we touched on before. I noticed, and you'll sense this talking to me or maybe listening to me sometimes, the excitement in my voice or passion about a certain thing. But I recognise it's a craving to be approved of through illusion of knowledge. And it doesn't mean you don't use that behaviour, but I'm now very aware of it. So, and controlling that excitement means that the interaction is much more successful because you're presenting a nervous system. If it's excitement, and I describe the basis for it in my little pop psychology as wanting to get success and praise from the interaction, somebody else's nervous system on this non-verbal connection, essentially it'll pick up threat. Potentially threat. So you both go in opposite directions.
Absolutely.
So setting the scene that I'd kind of was asked, I'd made a note to say, how do you feel you set the scene? Intuitively, I find myself just taking a few breaths before either a new patient or somebody I've had an interaction with, that I think it's important that I kind of regulate myself. But then actually, when you see the patterning of that, it's not a bad place to start as an habitual practice in any field, to be honest, never mind physiotherapy. It's nice to do it in life.
Absolutely. And that's well borne out in the psychotherapeutic and psychological literature, that clinicians or practitioners will ground and center themselves between patients or clients. So it's actually about being able to tune into your own process as well as tune into the other person, track your process, track their process. And in the same way, you're regulating yourself just by your presence and self-regulation. You will start to regulate the other person before anything's ever been said. The problem is that most of us come into the cubicle already upregulated with an idea of what should and should not be happening. So there's no room for anything different or new to happen. And when something weird and wonderful and novel does happen, like person bursts into tears, or, it gives you a hard time or whatever, because we're a little bit of a already preset in a way, there's not much wriggle room to modulate and work with that. Whereas in psychotherapy, they would go, just give me a minute. I'm feeling a bit overwhelmed by what you've had to say right now. I'm just going to sit with it for a little bit, and then you tune into you and I'll tune into me, and everything. There's no room for that in most of our physiotherapy consultations.
Yeah, that is fascinating. That awareness when you're with someone, I recognise, and this can happen on a daily basis. I know if I'm leaning forward. I can't wait to say something. I really can't wait to say something because I think you like it. No idea whether I like it or not, and just pause and wait, Drew, just listen again, just come back and listen. Now, so we're essentially looking at helping the patient access, become aware, or consider that there might be some unconscious patterns that are contributing to how they're feeling, very different to the point of focus that they've got their intent on. or that point of focus is relevant, but it's often a manifestation of lots of other things that you haven't yet seen or been aware of. So that's their presenting issue, if you like. And at the same time, we're dealing with our own unconscious patterns that are the filter, unless you are careful, through which you're going to address this or be with them. So if you're there with the wrong filter, you might as well not be with them to some degree. But I suppose... Sorry, go on.
Well, no, it's interesting. Everything you've said is really interesting for me. 9 times out of 10, physiotherapy is very successful. It does move people from A to B, and a lot of people are very happy with it, and they do really well, and physios, feel good about that. And, it's when things don't feel great that, and when physios don't feel great about working with a particular population, like people with persistent pain, that it starts to, unpacking that a little bit and seeing what's really going on is helpful for clinicians to not avoid working with people with chronic pain because they're considered too difficult, or whatever else, whatever other condition. But your leaning forward and curiosity will be picked up by the patient, because curiosity means you're interested in them. So it's not a bad thing at all to be curious and to know that when you lean forward, that's your curiosity. Because even Rogers, the positive regard guy who was all into relational stuff, said curiosity is one of the foundation skills of any successful practitioner. Meeting the other through your curiosity. What your attention is on is where does your curiosity go? If your curiosity is to see whether piriformis is firing properly and whether, they've got enough external rotation to stand on their leg, that's a very different form of curiosity. But if the curiosity is based on, how are you as a person responding and recovering from this experience you're having, and how are you responding to me, and how am I responding to you, and is my response helpful, is it not helpful? That's a very different form of curiosity, and that will be picked up by the client as well, because you're interested in their selfhood. Where are you in this experience, and what do you need in this experience, and how am I going to position myself or be myself to help you meet that need, and what needs to happen for that?
From an area of patients, or a subpopulation of patients that are very different from, like you say, the 8 or 9 out of 10 who do well with physio, it wasn't an area that I really I wouldn't say didn't like, but if you didn't get much success, you didn't get much reward or praise, neither did the patient, and your craving is to win, you can see how it doesn't appeal to lots of people for a long time. But actually now it's the place I love to sit.
Yeah.
And I don't need to win, which is interesting.
So what's enabled you, Drew, to make a shift from, I value myself as a physio for my outcomes that I get with this person, and my identity as somebody who can fix them or help them or whatever, to I'm happy to sit and, work with you through this process?
Well, I don't identify myself as a physiotherapy anymore, as a therapist anymore. It happens it happens to be something I'm doing at this stage in my life. It won't be permanent. I wasn't born a physiotherapist. I wasn't born a professional footballer, but I spent some time as a professional footballer. I'm a dad, and it'll always be likelihood I'll be a dad, whether people are here or not. I'll always be a dad, and I'll have always been a husband. I'll always be a son. But actually, they're all roles, and it's a little bit philosophical, I suppose. But I'm happy for those attachments. They're strong emotional bonds that I want to, I'd like to maintain as long as I'm conscious and here. However, some of the other things I'm less attached to. I'm less attached to praise. I'm less attached to achievement. I'm less attached to needing to know. I'm less attached to needing to fix. I recognise where these have come from. And it's not a traumatic background, although there could have been a traumatic background, and we've all suffered trauma, and it doesn't have to be massive trauma to be encoded. So, but I do understand the patterns. However, to work in this field, the less you identify with those things, I feel, it puts you in a position of neutrality a little bit. You sit in a place that's not adrenaline based as a state. It's
more GABA based.
Yeah, it's very easy for that person sitting alongside you to recognise that they'd like you to have some knowledge, some hierarchical position of authority in medical terms, so you can show them, suggest things that are interesting. If you talk too much, you lose them. You can suggest, and if they ask more, tell me a bit about that. But sometimes you give statements, I think, that are they're like, what? Like a functional MRI scan, it wouldn't matter whether you're thinking about grief or you're thinking about when you stubbed your toe, and they appear very similarly, or anecdotally. So people like facts. Some people like facts. Some people like stories. But I think if I don't identify with some of the things I have in the past, it allows the opportunity for things to come up much more human way, if you like. That you can explore some of the knowledge base if it's of help, but sometimes people respond or don't respond, but some people do respond with just those spaces, the gaps. And the not one trick pony, but the fascination of that all pain to go as a quick fix. It is fascinating when but it's not for every patient. But it was the process really of knowing that there is a pathway to recovery for everyone potentially. Irrespective of the starting point, it doesn't matter if it happens on day one or minute one, reading a book or speaking to someone, or epiphany moment, and it's almost like journey's a bit twee, but there's a meandering through. There's lots of stopping points. Sometimes there's an absolute stuck point at the start, and you might not be the right voice for that person. So I suppose in this process of speaking to you, it always fascinates me which way people approach what essentially is a very human desire to help somebody else who's in need of help, and asking for it at that point.
Yeah, absolutely. And, as I listen to you talking, Drew, I'm struck by the insights that you have. And in some ways, that same process is what I would be hoping would be generating in the other person is some insights and some awareness and some idea of what the next step is for them, rather than me directing the process, because that process unfolds in both of us. So it's unfolding in me. I'm not the same person now that I was at the beginning of our conversation. And as I listen and respond to what you have to say, I have my own, internal awareness around that, and where does that fit with me, and where does that not fit with me, and how do I feel about that, and what do I make of that? What story do I make up about that? This is what's happening all the time. And I think it's being able to recognize that what emerges within the therapeutic relationship, it can be completely different at any point. It doesn't have to follow a set script or a set pattern or a set, performance indicator or anything like that. And I think the world of managing or working with people with chronic pain, lived experience of chronic pain, is nobody does this 100% well yet. It's not a done deal. There's no, we've got this right yet. Even the best, programs only get, like 2 basis point on a VAS scale difference between, the super deluxe program and the, corner shop variety. So there's not a done deal of how to do this yet. But if the clinicians aren't feeling good about themselves doing it, then we're really kind of behind the 8 ball anyway. So a lot of my work is around, showing clinicians that it's doable and possible, and it's okay to be uncertain. It's okay to not get it right. It's okay to flounder around, and that's all fine, as long as we know that there's a process of unfolding here and emerging here that we can trust.
And do you see an evolution then? Your practice has evolved from 1980 something or other to where it is now. And I suppose when we met, or we connected a couple 2-3 years ago, do you see like new kids on the block? Oh, there's another one. They come onto the other side. They joined the matrix. He stepped through the matrix. Do you view it like that or not? But because I joke about it, but I think I just see a transition of the patient across to the other side of where they were, and they're like, I can't believe it. I had a day saying no. I've told my mother how to do this. They've cast. It's like what's the word? It's a keystone habit. You change one of them, it can just fall into place.
I think you're absolutely right. I think the wave of consciousness is, the 101 monkey thing. If 100 monkeys, all eat the red apple, but the 101 eats the green apple, then consciousness will change. So it's like there's a coherent story that's now got a volume of people who believe it, and so there's going to be a transformative element. We cannot go back to thinking of the body in the way that we were thinking of it 30 years ago. The consciousness of the whole physiotherapy population, the whole medical population has moved. Not everybody, in the transmission of innovation, they talk about the innovators, the people who get it straight up, then the majority, and then the laggards, and then the people who are never going to get it. So, I'm an early adopter. I'm not an innovator. So, somebody like Louis Gifford was an innovator who, synthesized all this information and put it all together. I just went, I've been looking for that. That's what I need to move my thinking along. Well, I think there's been a volume of people who have adopted the idea that pain is not about, just pathoanatomical dysfunction in the body, that there's a bigger reality around that. So there's been a flip, and that will build, on and build and change. And then we get to 101 monkeys and it will flip again. So how we do pain in 30 years is not going to be how we're doing pain now, or even 2 years. It's not how we're going to be doing pain now.
Yeah, it's funny. On social media, you get some weird streams come up, don't you? I don't know how I was on this particular stream that came up, the healthcare one, but I had a picture of a leech on someone's knee, and I was thinking, wow. And wherever that's from, doesn't matter. It wasn't the UK, it's for musculoskeletal pain, and it's obviously the central idea of that treatment for that protocol, and may well work in that. But it's so different from, I certainly wasn't taught that in physio school. I've never come across it in this paradigm, if you like. So there is a different points, isn't there, where people are at. And you can present these ideas to colleagues or patients and really get pushback. Do you? And that's somebody, maybe there might not be a patient, but there's a mere suggestion that you're approaching a persistent pain in this way can threaten somebody who, for them, it's actually some mechanism of comfort.
Yeah. So it's, you know, we've made up a lot of stories to justify the techniques and treatments that physiotherapy gives. So, you know, the story of core stability, for example, you know, there's a whole ontology about that. There's a whole version of reality that supports that story. And essentially, we're offering an alternative story or an alternative way of looking at it. And for me, I use the ideas around phenomenology to support how I see what's going on around me. And in some ways, that story will change with each person I see and with each conversation I have, like with you. You know, there's a whole movement now that of taking pain outside of the therapeutic alliance into the society. You know, there's a systemic collective trauma that actually causes chronic pain to manifest. It's part of the belief system, you know, that we're damaging the planet, you know, all of that kind of stuff. And that chronic pain would be a natural response to essentially living in a toxic environment. So that's a whole other dimension now. So the treatment for that will not be going to see a physio. The treatment for that will be good air quality, good water, good sanitation, good housing, good relationships. You know, it's not going to be about coming to see a health professional.
That kind of global or holistic approach though symbolizes how you should maybe start in the clinic room with that viewpoint. I've almost sometimes thought we should just go for a walk in this half hour. We should get out of this room if they can walk. And I genuinely thought about, I'm going to go for a walk with this patient next time. I haven't done it yet, but it popped up last week. I thought, and I did actually walk a man out to his car, an 80-year-old man out to his car. He said, "Oh, when I finish this, son," he said, it'll take me. The car's parked round the corner, and it'll take me till I get round the end of your clinic before the pain's gone. I said, "Okay, I'm going to walk with you." And he looked surprised. He said, I said, "Do you mind? Can I walk with you?" And he said, yeah. And his eyes lit up. And this is someone that 3 months ago could walk from the house to his bird cage to the kitchen to his chair, and he's doing 3,000 steps. Now, with him, it's actually keeping the reins on him, actually, because he's the life of pushing, climbing up mountains and one thing or another, and almost lost that identity from a knee replacement. Never recovered in a way that he thought was satisfactory, and then kind of dropped into the fawn response and stuck in that. Get angry, do too much, then come back down again. So he's doing really well, but I could see these beliefs. So he'd start to limp as he leaves the clinic, prepare the role for which. But me alongside him, we were chatting about his son, and he walked quite well, and we got to the car, and he didn't really get the same mechanism that he'd had each time he'd left the clinic before. So it's interesting, isn't it, when you think this broader perspective of cues, and people advise on diet and water and all those things that will affect us and do affect us. So we certainly have to take a different perspective to how we have, because it appears that chronic pain's getting more, not less.
It's a beautiful metaphor though, Drew, what you just said, like that walking beside, let me walk beside you. In some ways epitomizes the relationship that I would be supporting in clinicians, is that I'll walk beside you, have my experience in the same time, acknowledging and validating your experience, and let's see what we can do together to see if we can do something different, have a different experience. So, you know, having you beside him, if we were able to put that under a microscope, you know, he might have felt that more validated, you know, having that emotional support to get to the car, you know, to have the distraction of you talking about life affirming things and important things that made him feel good, keeping the balancing hormones and neurotransmitters going from what was set up in the clinic, synchronizing his nervous system with your nervous system, adding some fun and some, you know, all those human attachment and human interaction things and all of that stuff, not having to walk to the car on his own, not having to do this on his own, not being so isolated, you know, all of those are just as real and important to people, but often we don't pay attention consciously to that sort of stuff. And I suppose where the world is going with pain, particularly within the world of pain and psychotherapy, is paying attention to that. Because the body is really just messaging what the whole system is doing.
Oh, it's taking me back to this spiritual thing again. It's so, I don't know if you read Eckhart Tolle and New Earth, but it's so overlaps. And I don't know which comes first, chicken and egg, whether he's read some stuff in them. It's all the same stuff churned out. If you read any book on this subject, they come at it from slightly different slants, but it always comes back to the same place. There's only so much content, isn't there, and then it's span around different ways. But if you can see a different way to pain, and you certainly do see it in a way that lots don't, it's fascinating to listen to you, and I'm very grateful for meeting you and having time with you. I certainly see it different, and whether that's on the other side of the matrix, whether that's some sort of individual evolution or some collective evolution, it's a lovely place to be, I feel anyway. Not that it wasn't lovely before, because you only know what you know, but it's something that I hope anybody watching this will they will pick up on the essence of what you're saying, and it's the integrity behind it, and hopefully be inspired to explore it some more, because you've inspired me, Shelley, and you know, I have loads more questions. I appreciate you giving me an hour of your time. I'd love to catch up here again another time and just bang loads of, I don't know, like the classic questions to you that we all get asked, because I'm sure people would love listening to the answers to them.
Oh, thank you, Drew. That's very kind of you. But can I ask you a question? I'm curious. What is it you think I'm saying?
It's not what you're saying. It's not what you're saying, actually. Now, I leave other people to work that out. It's how you've made me feel. It's how you made me feel now. So non-verbal, verbal. It'll be tone in what you're saying. There's words, but I see your eyes. I see your smile. There's a resonation. We're half a world away. I'm just waking up. But I've been listening intently to everything you say. I'm not dressed from the waist down, but you wouldn't know. But I didn't care. We've had humour. You've listened to me. You're genuinely interested in some of the things I'm doing, or you appear to look that way. I'm fascinated with what you. So there's a connection. So wow, does that answer your question? Thanks very much for your time, Shelley. Thanks very much for your time.
Thank you, Drew.
We've had some fun. I hope you enjoy the rest of your evening.
Thank you so much. And thank you for the opportunity.
And we'll chat again sometime. Cheers, Shelley.
Okay.
I'll be in touch. Okay, bye-bye.
Yeah. Bye-bye.